I'm just going to adjust the lights, not so that we're totally in the dark, but that should bring them down a little bit. Oh no, off. I need to press off, don't I? Yes. So, first of all, I want to say thank you to well, Alex and Leah, and thank you for that nice introduction, Justin. I don't know if all of you, anybody who works at Life Care probably knows that 8 long years ago, I started off at Life Care when I first came to Australia, and for that reason, Life Care will always have a very special place in my heart because nobody else would give me a job. And I opened the Yellow Pages one day. These Yellow Pages, yeah. I opened the Yellow Pages one day, and the first advert was Life Care. And so I thought, I'll give this chap a call, see if he wants a periodontist from England to work with him. And he was like, yeah, come in, you know, I'll sponsor you, I'll give you a job, and you know, and I worked there until I got my specialist registration, which took about 3 months, and then I worked there for an extra year because I had such a lot of fun there, and I met lots of really nice people, and yeah, I really enjoy my time at Life Care, so I'm always honoured and touched when Alex asks me to give a little lecture. So today I want to speak to you about periodontal plastic surgery because this is a matter, this is a subject that I've been dealing with for around about 12 years now since I graduated from Perio. What I want to cover today is a little bit about the definitions and classifications of recession defects. There's so many things that we can speak about with periodontal plastic surgery. One of them that Justin even mentioned, which was, you know, the pink aesthetic score. And I'm not going to go into that because I think that's like a whole separate lecture. And I'll speak a little bit about the etiology behind recession. Some techniques which are available and the success rates that go with them, and a little bit about some new advances within periodontal plastic surgery, some new materials like something like mucograft. If you've heard of it, you may have heard of it, and just finish up with some clinical cases to give you an idea of what can be achieved from a pink viewpoint. So for those of you that didn't go to Life Care 8 years ago, this is a little bit about me. I graduated in 1992 from Guy's Hospital. Yes, I have a very young looking face. I'm much older than what I look. They have the dental school. I don't know if any of you know Guy's. Dental school is located within the top 10 floors of the Guy's Tower. Always a surprise to me when you consider that dentists have the highest rate of suicide of the professions. So once I'd finished here, I went to this place here, the Royal College of Surgeons, completed all my fellowships, and then I did my postgraduate training in 1998 at the Royal London Hospital. I've done a little bit of teaching at Aqua with the postgraduate students in periodontics. I don't teach there anymore. I'm located purely in private practice at Subiaco, and we call ourselves Elite Perio. And there's myself and Dr. Zahida Oakley there. So I moved here about 8 years ago, and Elite Perio has been up and running for about 5 years now. So we're having a really good time playing with gums there. So these are the different types of procedures which are involved as far as periodontal plastic surgery. And you know, you have corrective procedures, and those corrective procedures can be caused by a variety of different reasons, and the defects which can be classified as periodontal plastic surgery is really affecting both the gingiva, the mucosa, and also the bone. I'm really going to just focus on soft tissues today. So the types of procedures that you would have, you know, that you would encounter, and these are all patients that we've seen, you know, are things such as, you know, this is vertical maxillary excess with a little bit of delayed passive eruption. I'm very surprised that we're being filmed today. That case was one of the last times that I was filmed, which was for Extreme Makeover in the UK about 10 years ago now. They wanted a gum lifter because they wanted to lift everything in that program. So one of the things that they thought they could incorporate with the breast lifts and the face lifts was a gum lift or a crown lengthening surgery. So that was just one of the cases. These types of cases, such as single tooth recession around implants, here is a recession affecting an implant, are all things which Muka, and here's recession which is associated with inflammatory periodontal disease, are all sort of things that we encounter within our surgeries. Does any of you do any type of grafting at the moment, apart from sort of like grafting around implants, which I think majority of people who are placing implants do a little bit of bio or spire guide? Does anybody do soft tissue grafting? But you know how to recognize when things might need to be done. And also, it's quite nice to know for your patients about what sort of success rates you can expect from these different types of grafting procedures, because there's no point in having a class 4 recession defect that you can't actually, you can't actually improve on. So, and you need to know the reasons why you can't improve on there. So the soft tissue procedures that we're going to really talk about today are free gingival grafts, connective tissue grafts, muco graft. Does everybody know what alloderm is? So alloderm is basically other people's connective tissue. I think it's not TGA approved here in Australia, but you can have one of these, like getting your patient to sign a waiver or something like that. I really don't like the idea of that. The other types of grafts are things such as pedicle grafts and coronally advanced grafts using a GTR membrane. These are not types of things that I do, because the literature shows that these things don't really have very good success rates. So if you want to choose something like this, which has got an inferior success rate to something like a free connective tissue graft, then you have to have a good reason to be able to be opting to do that. So I might use some of these as in combination to other procedures, but the success rates, for example, of pedicle grafts, coronally advanced grafts, as far as root coverage procedures, is something like around about 75%, whereas with connective tissue grafts, you can expect something like a 90 to 95% improvement in root coverage. So it has a very good success rate when it's and very predictable success rate when it's done in the correct way. So this was an interest. I'm not going to sort of present a lot of studies today because it is the evening, and I appreciate that you've all come here from work. But this was an interesting study which looked at the prevalence of recession which was greater than 1 millimeter. And it was a study that was done of about 10,000 people in the USA. And what they found was that there was quite a lot of people who had recession of 1 millimeter. And the recession generally increases with age, which we know. And it's more severe, sorry about the typing, more severe at the buccal surfaces and in male patients. And I think that might be because of the amount of male patients that go back to we know that male patients tend to go back to the dentist more infrequently than female patients. The female patients tend to have a higher sort of like compliance rate with maintenance treatments. So that might be falsely elevated for that reason. So basically, until the 1980s, periodontal plastic surgery really focused on making things functionally better. So frenectomies, I'm sure lots of people here have done frenectomies. And there are various techniques for doing frenectomies and using a laser or not using a laser. Gingivoplasties and lateral precision flaps. Again, I'm not really going to talk about any of these. But in the 1980s, this new surgical technique came out, which was called the free the free mucosal graft or free gingival graft. And this was brought about by someone called P.D. Miller. Now, this guy I watched an interview with this chap, and he's a periodontist in private practice. He's such a cool guy. He was just working every day in private practice, and he started to do these connective tissue grafts, and he found that he got really good results with them. He got good root coverage, he had predictable treatment. So he wrote to the American Academy of Periodontology, and he said, look, I'm getting these great results with this type of technique. I know not a lot of people are using it, but you know, this is actually working really well in my hands. I think it's something that we should publish. And basically, they told him to get on his bike and said, you know, this in England means no. Yeah. And they basically said to him, come back to us when you've got more cases. So what he did, yeah, was he went back to his private practice and he did 100 consecutive cases. And then he went back to them with his results. And he got greater than 90% root coverage in his 100 consecutive cases that he got. Even though case reports are, you know, quite a weak form of evidence as far as, you know, it wasn't a randomized controlled trial that was done. I think that the amount of evidence that he presented from a private practice perspective actually was a paradigm change in periodontics as far as soft tissue surgery is concerned. And then they decided to publish his results and actually invited him to lecture at the university. So this guy, if you ever get to watch that interview with him, it's a really nice interview. And one of the best things about it is, to me, it shows that within private practice, you can actually do really like groundbreaking stuff. And it makes a difference to science as such. So, you know, I really like that about his story. And it's because of P.D. Miller that we have actually a classification of gingival recession. So this was his classification. Do you all know, if any of you heard me talk about recession before, and you know about these things. If any of you want these slides, just let me know. You can just email me and I can give you a copy of these if you like. But a class 1 recession is where the marginal recession extends up to the mucogingival junction, okay? And there is no loss of interproximal bone. This is really, really important because his classification of recession actually is a way of predicting how successful treatment will be. So in this type of a recession defect, you can actually expect 100% regeneration of this recession. Okay? So this is one of the nice things. Class 1 recessions respond very well to soft tissue grafting. Class 2 recession, this is marginal recession, which extends up to or beyond the mucogingival junction. And again, there's no loss of interproximal bone. This is really, really important. The limiting factor in gingival recession is the interproximal bone. This is actually the very first case that I ever did. It was in like 1999, as Prince would say. And, you know, it was a really positive experience for me because I got 100% improvement in this recession. With a very classical procedure. Class 3 recession. This is when you have the recession extending in a similar way to the previous case, up to or beyond the mucogingival junction, but the amount of interproximal bone, okay, is reduced. It's not reduced to such an extent that it's at the same level as the apex of the recession, but it is getting there. So we know that the limiting factor is the interproximal bone level. And because the limiting factor is the interproximal bone level, we know that the amount of recession coverage or root coverage we can expect from this type of a procedure is only about 30%, okay? In this case, would that improve things? Sure. We know that improving somebody's keratinized tissue, we know that evening out the gingival margins will improve their oral hygiene, will facilitate their oral hygiene. So anything that we're going to do to facilitate their oral hygiene, get them to have more comfortable brushing in that area, is going to mean that they can maintain these compromised teeth for a greater amount of time. So there are other reasons other than root coverage that you may want to repair gingival recession. A class, them little arrows there. Class 4 recession. So this is a class 4 recession, and this is where the recession is equal or almost equal to the papilla height. What we know about papillae, and this was done by Dennis Tarnow's group, and what they said was if you have the papilla, underneath the papilla, you have bone at approximately 3 millimeters under the papilla. So if you have your apex of your recession here, your bone here, how much root coverage are you going to get? 0. So you're not going to improve this root coverage. And unfortunately, these are the type of people who always say, oh, they look so ugly, doc. You know, can you do something about it? So in these cases, again, you may opt to do some sort of soft tissue plastic surgery procedure, but the objective of it ought not to be root coverage, because root coverage in this situation is extremely unpredictable, and the degree of root coverage that you will get from a periodontal plastic surgery will be 0. So these things, one of the nice things about this classification system is it tells you a lot about what can be achieved post-treatment. So some common questions that I get asked all the time, which is, you know, when do you need to do some gingival grafting? My patients ask me, does it hurt? What's the recovery time, and does it work? Does it need to be redone? And is it caused by brushing too hard? I'm going to cover a few of these questions. So when do we need to do some sort of grafting? So a good time is when there's no keratinized tissue. Okay? When orthodontic treatment is planned. So if you plan orthodontic treatment, then if you already have a thin gingival biotype and you are going to orthodontically move tissues in a facial direction, there is a very high chance that you will create more recession. You have two options. You can correct this recession before it happens, so you can slow it down by thickening the biotype, or what you can do is correct it once it's actually happened. Depending on how much the orthodontist is going to move the teeth will depend on whether you choose to do it pre or post ortho. Pre-prosthetic treatments, these are another time that you would do grafting. Root sensitivity, I think that's quite an important time to actually consider gingival grafting, especially around upper canines, upper premolars, very predictable to repair these types of recession defects. For aesthetic reasons, I get this all the time for patients with high smile lines and aesthetic reasons. To facilitate the oral hygiene, in general, these types of patients, I tend to get those patients who have already treated their periodontal disease, and then, it's around lower incisors or around upper molars where we want to actually ensure that they've got good oral hygiene. And especially you need to consider repair of recession when the recession is increasing over time. So if you have recession which is greater than 2 millimeters over a period of 1 year, then this would be classified as increasing recession, because probing error is approximately 1 millimeter. So you need to have a 2 millimeter change. It needs to be the same person looking at it. And if you can have photos or models, that would be even better. So a lot of you will have sent me patients for some sort of soft tissue grafting, and quite often I write back to you and I say, please can you take dated study casts so that we can monitor this recession, and then we get the patient back in a year and we see if that recession is actually increased or not. In general, most people who have that type of recession actually have it with quite good oral hygiene. When shouldn't we graft? Well, of course, if we've got a really horrid mouth, we ought not to graft.